everyone. Am I audible, Tim?
I can hear you.
Okay, thank you. Welcome to our ECO session. My name is Mercy Shabang. I will be today's facilitator for the session. With me, I am with Pius Pumayo, our Lubombo Palliative Care Regional Nurse. Can we kindly introduce ourselves? Maybe I can start with Sandile Mashamu. Please introduce yourself.
Hi, colleagues. Thank you so much for joining, and apologies for the delay. My name is Sandile Mashamu, Eswatini Hospice at Home Eco Coordinator. I'm happy to be with you today.
Thank you, Mr. Mashamu. Can we move to Thandazile?
Good afternoon, colleagues. I'm Thandazile Simelane from Manzini Government. Yes, here it's Thandazile Simelane from Manzini Government Hospital, Palliative Care Department. I'll be joining with anyone, but she just moved out now. She'll be back soon.
Thank you, Thandazile and Annie. Can we move to Malaika? Please introduce yourself.
Hello everyone, I'm Malaika Sarin. I'm from ECHO Indian, representative for Eswatini Hospice. Thank you.
Thank you, Malaika, for joining us. I thought I saw Cyprian, but maybe he's going to join us as the session continues. So last week we were looking at opioid prescribing for chronic pain. And this week we are going to looking at risk mitigations. That we should have our gadgets muted or on silence, and we should be mindful of background noises to ensure that our session runs smoothly. If there's anything that we want to communicate, we can always use our chat box or the raise of hand. So at this time, I would hand over to Mr. Pumayo to give us today's presentation.
Thank you very much, Mercy. As I've been introduced, I'm Pius Pumayo, and I'll be presenting today's didactic session. We will tackle the topic on risk mitigation strategies for opioid prescribing for chronic pain. Can you please excuse us for a minute?
I don't know if it's possible for Mr. Mashamu to share the screen. Mr. Mashamu?
If Mr. Pass can stop sharing, I can do.
Okay.
Yes. I can share a little bit. I think 2 minutes I'll be then sharing.
Okay.
I hope now you can see it.
Yes, yes, it's
Thank you very
perfect.
much, Mr. Mashang.
Okay.
As I was saying, colleagues, today we'll be tackling the topic on risk mitigation strategies for opioid prescribing for chronic pain. So for starters, we'll start with definition of terms. Oh, pardon me. Let us start with the our today's objectives. By the end of the session, participants should be able to apply universal precautions to identify and access opioid use and prevent opioid use disorder. Also, participants are expected to differentiate between opioid misuse and opioid use disorder. We will proceed to our definition of terms. As clinicians, we always need to understand the following terms. Serious illness, which is referred to as a health condition that carries a high risk of mortality and either negatively impacts quality of life or daily function or excessively strains caregivers. Chronic pain, which is a brain disease that frequently limits life and work and is associated with functional impairment, depression, anxiety, substance use, and reduced quality of life. Opioid misuse is referred to taking opioids in a way other than the prescribed. Opioid use disorder is a brain disease that is a subset of substance use disorder specific to opioid. It is often characterized by altered brain chemistry and compulsive use of opioids. Lastly, we will define prescribing, which is a clinical supervised process of discontinuing medication that is no longer beneficial or whose risk outweighs the benefit. So now we'll look at the best practices. Let's continue, Mr. Mashang. We will now look at the best practices in opioid monitoring. We have function and pain assessment, assess for risk and benefit, use informed consent, and urine drug test as indicated. Now we will be differentiating opioid misuse from opioid use disorder. Opioid misuse, opioid use is outside of prescribed parameters. It ranges from a simple misunderstanding of instructions to self-medication for other symptoms to compulsive use driven by opioid use disorder. It is not the same as opioid use disorder or substance use disorder. It is the clinician's responsibility to differentiate opioid use into substance use disorder or other causes. Now let's briefly look at the signs that may indicate opioid misuse. The first sign may be pattern of lost, stolen, or missing opioid medication. So this may be said by patients. The patient may also verbalize the clinician may notice patterns of running out of medications early, taking opioids for symptoms other than pain, using more opioid medication than prescribed. Also, aggressive behavior may be noted. Lastly, risky co-use of alcohol and other substances may be signs that may indicate opioid misuse. Opioid misuse-related factors include poor health literacy, misunderstanding of prescribing instructions, definitely by clinicians, cognitive impairment, disease progression, undertreated or worsening pain, and lastly, inconsistent or no availability of medication. So when evaluating opioid misuse, we should consider doing the following. First, we need to identify instances of misuse. In many of the listed opioid misuse behaviors, a single instance of behavior is a data point that may not indicate opioid use disorder. Also, we must use a differential diagnosis. Here, clinicians should ask the patient for an explanation of a certain behavior and develop a differential diagnosis. For example, the clinician may ask the patient, what happened that caused you to run out of medication early this month, but not in the previous month. Also, recognize patterns. A pattern of one or more behaviors is concerning. For instance, several missed appointments combined with aggressive behavior may trigger awareness of possible opioid use disorder. Lastly, prevent implicit bias. We all know that implicit bias is also referred to as unconscious bias. These are basically attitudes or stereotypes about groups of people that occur without being consciously aware of them. So all people have unconscious bias, and these biases influence our behavior and judgment. Okay, now we'll look at factors that increase patient risk for opioid use disorder. Factors that may increase a patient risk for opioid use disorder include personal history of a substance use disorder, strong family history of alcohol and other substance use disorder, certain mental health diagnosis, lastly, use of certain psychiatric medication. I think it is worth noting that clinicians should take extra monitoring precautions when patients have known risk factors of opioid use disorder. Let's continue, sir. We'll briefly look at universal precautions, which these include regular visit at least every month or frequently. Second, the opioid treatment agreements. Here we use an opioid treatment agreement trust through communication and set boundaries and expectations with patients. Potential risk can be detected as clinicians and patient talk through agreements. It is worth noting that opioid treatment agreements are intended to mitigate the risk of opioid misuse through education and establish expectations and boundaries in advance. Also, opioid treatment agreements may include the following: informed consent, patient responsibilities, prescriber responsibilities, and lastly, conditions under which opioids may be stopped. Another parameter we'll look is urine drug testing. Urine drug testing is used to identify agents the patient is or not taking. Is controversial. It is highly recommended for use in patients on long-term opioid therapy. Also, lastly, naloxone training and provision is also part of the universal precautions. Naloxone is an overdose rehearsal medication shown to save lives. It is common to practice to provide naloxone to individuals who are particularly at high risk of accidental overdose. If opioid misuse is noted, clinicians should take the following step, that is, responding to opioid misuse. So firstly, do not immediately stop opioids. Secondly, develop a differential diagnosis. Using more opioid than prescribed or requesting early refills could indicate disease progression or increased pain or even lack of access to opioid in local pharmacies. Determine whether there is an opioid use disorder or substance use disorder present. Lastly, with determining whether there is an opioid use disorder or substance, you may use the diagnosis DSM-5 to criteria. Lastly, intervene. So now we will briefly look at the risk mitigation for patients on long-term opioid therapy. Okay, you just follow the following 4 steps, which are step 1, opioid risk benefit analysis. Step 2, you assess whether the patient is of standard or high risk. Step 3, use the universal precautions that we mentioned earlier. Lastly, if misuse occurs, develop a differential diagnosis to determine the likely cause. Okay, differential diagnosis of opioid misuse, they are as follows. It may be due to undertreated pain, miscommunication or head literacy, diversions, pharmacy issues, or opioid use disorders. Okay, in a nutshell, ladies and gentlemen, social determinants of health such as poverty, education level, food, and housing security can all impact patients' adherence and give the illusion of opioid misuse. Medication availability in some communities is also an issue. Lastly, clinicians must do a comprehensive history and exam to develop a differential diagnosis on individual basis. Thank you very much, ladies and gentlemen. This marks the end of my presentation. I'll hand over the reins back to our facilitator.
Thank you, Mr. Pumayo, for the presentation. It was very insightful. I believe that we were all able to follow through the presentation, colleagues. So if there's any questions that we have, or if there's any comments or additions that we'd like to make, this is the time for that, colleagues. I'd like to comment on a few things that actually did capture my attention a little bit more, is that there are signs that do indicate opioid misuse, which we are supposed to be, which we are supposed to take note of, because they even help us get to the differential diagnosis, as it has been explained during the presentation, and also that there are related factors that could actually increase the risk of opioid misuse. So I think as we do prescribe to our clients, it is important that we look out for any signs that could indicate, and obviously avoiding any form of biasness as we do that. I don't know if we have any questions or additions or comments. We can use the chat box or the raise of hand. I see a hand from Mr. Mashangu.
Okay, thank you so much, Messi. What I can add is that maybe to emphasize that most of the time we find ourselves quickly maybe going towards saying a patient is opioid misuse, has developed an opioid disorder. without eliminating the issue of dealing with the opioid misuse. And most of the precipitating factors for opioid misuse, you can tell that most of them, they are due to factors we can control. One of the things that I've noticed is the issue of communication and underpain treatment. So we need to assess. There was one patient that was shared by RFM. I thought they will be here today to share what the patient was experiencing. It was easy to say that patient was was now have developed opioid disorder. Yet you will discover that the patient is already misusing the opioids due to different factors. And if we can first or concentrate on the medical issues, we can end up missing the psychosocial aspect, which has been clearly revealed that it do contribute significantly towards opioid misuse. So we need to manage our patient holistically. That's what I can add.
Thank you, Mr. Mashang, for those additions that have been noted. There's also a hand from Cyprian.
Afternoon, team. I think one way to, I think another way to reduce the use of opioids is to reduce the number of days. Like if you have prescribed for a month, just prescribe for 2 weeks. See if the patient will continue misuse the drugs. If she continue, just lessen the number of days you have prescribed for. That one, I've seen it's helping. Or rather, the client may come to the nearest facility to come and get the drug for that particular day. Then that one will go according to your assessment between the health worker and the client himself or herself. Yeah, I think that's what I wanted to raise.
Thank you. Thank you, Cyprian. I think it also goes back to there's a point in the presentation that said you do not just abruptly stop the opioid prescription. So thank you, that is very well noted. I don't know if we have any other additions or comments. Okay, there's a comment from Tandazile. It says, I missed some part of the presentation where you mentioned the opioid misuse and and substance use disorder. I don't know if you can still share the slide, Mr. Mashangu, so that maybe we can go back just a little bit. The slide on opioid misuse and substance use disorder. Mr. Mashangu, are you able to share from your side?
I think, I don't know if Kadazle is referring to when Mr. P was trying to explain the difference between opioid misuse from opioid use disorder. I don't know if that's what she's asking.
Okay, she's saying here just before the signs that may indicate opioid misuse.
Oh, yes.
I was hoping that maybe that slide is going to give us a picture of what we were trying to say.
He was differentiating between opioid misuse and from opioid use disorder. So actually he was trying to explain in depth what exactly is misuse, opioid misuse. So when he was saying that opioid misuse is the use of the opioids outside the prescribed parameters of that drug that has been prescribed. And then he also mentioned that opioid misuse ranges from a single misunderstanding of instruction to self-medication for other symptoms. You'll find that a patient will be taking morphine just for sleep, or he will be taking this just to feel numb. So Now he's using the drug for other things. You find people who will be taking a drug and saying it's for other businesses. The trial is not allowed to take morphine for diarrhea, even though we know that its side effects will lead to constipation. But then once you begin to use it for diarrhea, not for pain, then you will discover that then we call the one opioid misuse. So he mentioned that opioid misuse from the difference with opioid use disorders, that the patient will begin to use the drug for different reasons that maybe sometimes are medically justified, but not for the drug as it is meant for. And then he also said that it moves from that misunderstanding of the instruction to compulsive use driven by opioid use disorder. Then now he begins to abuse the drug, then he moves towards the class of opioid use disorder. Otherwise, he was just saying opioid misuse disorder is not opioid use disorder, because you find that it's just an issue of misunderstanding or miscommunication. So that's what he said very well there. And then he said that then it's our responsibility as clinicians to tell if the patient is really abusing the drug in terms of has developed an opioid use disorder, or is that a misuse for that time, and we can trace even the causes of that opioid misuse. Then once we have traced those opioid misuse issues, then we can trace and then help the patient deal with that, or we can address those issues. And then he mentioned that some certain issues that can lead to opioid misuse may just include that the poor health literacy, the patient doesn't know exactly what has to be done and fail to understand what exactly the clinician said the prescription is. So you don't know what exactly to do. Some, then you will find that they are cognitively impaired. So if you prescribe an opioid to a cognitive impaired patient, you may discover that they will end up misusing that opioid. Sometimes due to progression of the disease, you find that the patient is in stage 1 and then later stage 2, 3, 4 as the disease continues. And then we know that progression of disease is it comes with increase in pain. So the patient will experience more pain, and then he will end up misusing the drug because he will take it outside the parameters of the prescription. And sometimes we will find that we will undertake a worsening pain due to different factors we mentioned before that can affect the assessment of pain. Then you'll find that the patient underreported the pain or we undertreated the pain. And then while the patient is at home, then we will increase the dose, and then that will be called misuse of the opioid. So yeah, those are the things maybe he mentions, maybe without maybe going back to the slide. I think that those are the things that we can then say the patient. But then once the patient is opioid use disorder, then you'll find that now the patient has become a compulsive use. Once the patient has become compulsive in using that drug, then we say the patient has developed opioid use disorder.
Thank you, Mr. Mashamo, for that clarity. I believe you have been answered, Tandazile, but if there's any other maybe follow-up questions, feel free to write them in the chat box. We will tackle them. There was a hand from Cyprian. I don't know if there's anything that he wanted to share or ask. Is
No,
there
okay,
anything?
before
Oh, okay.
no,
Thank
my hand is down.
Okay, thank you. So thank you so much, colleagues, for that interactive session. So we are going to move to our case presentation from Cyprian Matenjwa, who's joining us from the NCCU team. Kindly introduce yourself, Cyprian. We missed you during the introductions, and please let us know if you're joining with anyone, then you can start your presentation.
Yeah, I think I'm okay now, colleagues. I've been trying to like sort the things, this presentation here. Are you able to see? Are we all able to see the presentation?
Yes, we can see from our end.
Just a minute, please. Okay. Like I've been introduced, my name is Cyprian Matunja from the NCCU. So my client here, I have the case ID there is 570511. Then it's a male, 66 years old of age, diagnosed with prostate cancer. So his main problem, patient should get treated. My main aim is that client should get treated before the condition gets worse, and navigate, since I'm the navigator here at the NCCU, and follow the pathology results so that patient can get further treatment. His chief complaint was inability to pass stools, tremendous weight loss, and anemia. Since you know that cancer patients who are on chemotherapy, they've got problems with anemia and weight loss. So this client actually, she had a problem with she had diagnosed with prostate, but now she's complaining of unable to pass stool. Then some examination was done, anal examination under anesthesia. They discovered that he have got a mass on the rectum. Then now, as the navigator, was to fasten the results so that the patients so the doctors may see what's that mass in the rectum. Is it cancerous or non-cancerous? But while I'm still presenting, I think we got some highlighters. What is it that was troubling the patient? Okay, under the characteristics of pain 1, quality, I've discovered that the pain is somatic because it's from the tissues. Location, it's from the anal region, since it's from the rectum. The pain intensity, it was 9/10 without morphine. Then it's worse when the patient is going to the toilet. My patient is chronic. Cancer is chronic. Then aggravating factors is for patient pass stool. Relieving factors, the patient became better. I mean, the pain becomes better when the patient is moving around. Then the functional impact on the pain, it's mild. Current analgesic is he's on morphine, 10 milligram 4 hourly. Then another thing that I've discovered to this patient wasn't taking the medication as prescribed. As a result, he couldn't sleep at night because he was taking the medication PRN. So I corrected that with the clients to take the medication 4 hourly. So now we said the morphine can control the pain since now he's taking 4 hourly. So mid-effectiveness, it's partial. So physical assessment, client is ambulant, but emaciated plus. He had lost so much weight. Then there are signs of pallor from the hands, even from the conjunctiva, but we didn't do the full chemistry yet. Becoming tired when you're walking fast. He has to walk steadily because when you walk fast, you then become tired. Psychological effects, aspects, the patient is fully conscious, well-oriented in time, place, and person, no signs of confusions, no signs of dementia. He can recall whatever activity that has been done before. Work status, he's a retired teacher, no longer working now. Educational level is tertiary, of course. He's a middle class patient. Married, yes, she is married to, sometimes it comes with the wife, more especially now when the condition is becoming worse. Lifestyle habits, non-smoker, no history of alcohol consumption. Then other social related information. Yes, patient has got his wife next to him who is assisting him most of the time. He also goes to church. They've got church members that visit him while he's at home. Then other spiritual aspects, yes, I've already said he's a believer at Nazarene. She goes to Nazarene at his own church. Significant medical and surgical history of prostate cancer, finished chemotherapy. So that's why he's losing weight. That's why she sometimes look anemic. No history of surgery. So his medication is taking Precautions. He's taking maxolone ferrous and folic acid together with the chemotherapy. I think there's quite a number of medication he's taking, but it's just the limited that I've written. No, currently is still on Precautions, HCTZ, ferrous sulfate, folic acid, morphine as well. Of late, they have prescribed nystatin because of the tongue. You know, if you're not eating properly, the tongue then become like having some small sores in the mouth. Even the mouth becomes it develops some sores if you're not eating proper. The DNR is not done. Will no advanced decision on treatment. Yes, he's on treatment. He's willing to take treatment. Mental capacity assessment, yeah, is normal. I think the psychological aspects. No, I cannot complain of anything there. Comments on consent, just worried about carrying the urine bag, because now of late they've said clients must do a procedure. Now he's admitted today at Mbabane government for possible colostomy so that they can be able to pass stools. The vital signs, temperature 36.2, BP 120, 62, pulse is 84, respirations 24, and the saturation is 96. So according to me, there's nothing wrong there. According to the eco assessment, ECOG1, I've noted that the client, yeah, he's able to walk. He's ambulant, but getting tired when you walk faster. That's in that place I decided to write one. And equal to I've recorded 2 because client is ambulant, can take care of himself. The rest is 0 zeros. Then I've said the pain assessment, it's 9/10 without the morphine, but with the morphine, the pain become controlled. There's no dyspnea, there's no anxiety, no agitation, no depression. Depression is there, but we've spoken part of the depression because client was worried about carrying this bag with feces, and they're having another bag with urine. So he said it's gonna be too much for him. But with the doctor, because we have been there with one of the surgeons, he spoke on behalf of the thing that he won't be smelling. This thing would be covered in a small bag, which means to be emptied. I think he got education by turning the colostomy bag. Drowsiness and fatigue, yes, he becomes tired when he walks faster. Noise and vomiting is none. There's no noise and vomiting. There's only dry mouth there. I've noted the dryness of the mouth. It's there. Okay, and current labs, yes, my duty as a navigator was to trace his results at Mbabane government since they did the biopsy, the rectal biopsy. Then we have challenges at Mbabane government. Sometimes we run short of reagents, sometimes we run short of alcohol. But in this case, the alcohol, I mean, the reagents were there, the alcohol wasn't there. So luckily, within a week, the alcohol came back. Then I asked the technicians to fasten the spacement. Then we got the spacement not very long ago. It confirms the mass on the rectum that it was cancer again. So even that diagnosis depressed the client. You've got 2 cancers in one body. There's no way you cannot be like depressed. So the doctor, they break the bad news to the client. So I think it's one of the topic in palliative, how to break bad news, possible future plans that you want to do a colostomy. Yes, patient agreed and he's scheduled. He was scheduled for 25 of August 2023 to see the surgeon, because the one you saw on that particular day wasn't a surgeon, but it was a general practitioner. So he saw the surgeon, and the surgeon said patient should be admitted today for possible not colonoscopy, it's colostomy. I'm sorry for that. So client now is in the ward. So the future plan is to do chemistry so that you can see the blood levels. You know, I say patient has got some pallor. If the blood is, the HP is low, we need to transfuse the patient in preparation for the procedure. Now, tomorrow we'll be going to the theater for the colostomy. Since we have agreed, we know that the patient has to be involved in the plan of care. Since he's the one, since he is the one who's going to carry both bags, the one for the urine and one for the colostomy. For possible blood transfusion, if you're going to do some procedures, especially the big procedures, you must go with some blood there. So as a navigator, I've got to link the blood bank people to give us maybe 1 or 2 units before client go to the main theater. We know that palliative client is not a one-man show. We need multidisciplinary team, the surgeons, the nurses, the physician, the pathologist. So all of the team, I made them to be involved to this client so that clients can feel can consume their services, if I can put it that way. Then to reduce the burden that the patient might feel financially. Sometimes the patient, since this one is a pensioner, sometimes he cannot pay for some of the lab tests. So if so, us as navigators have to go to people who can help him to have some of these tests done. Family involvement, yes, there is the wife who's there, who's helping him. Not unless I've got to share some of these slides. I am allowed to share some of these slides, but it doesn't have the patient's name, but just for clarity. Can I go on?
You can say as long as it doesn't have a patient identity.
Okay. Say stop. Yes, like I've said, the patient has been like coming to the hospital for chemotherapy, since he's a prostate care client. You know, our chemotherapy destroy the red blood cells. So patient has been transfused. You can see the updates, there is transfused 2 units. Then that was the TTOs, the take-home medication he was taking. There is a tramadol there. The client was given that weak opioids, tramadol. Client has been taking like iron tablets to maintain the patient's hemoglobin. If you look further, his client there, the client there has been weak sometimes due to the chemotherapy he was taking, and the client started like complaining about difficult in passing stool. So sometimes you can mistake it as if it's the constipation from the morphine. Yet for him, it wasn't the morphine, it wasn't the mass that was there in the rectum. Until the patient
I think we have lost the Cyprian now.
Yeah, it seems we have lost Cyprian team. But I think he had finished his presentation. He was just sharing with us some of the medical notes, just giving us a history for the client's treatment and possibly diagnosis. Okay, maybe we can give him a few minutes whilst he's trying to reconnect.
He's back now.
I'm sorry, Tim, there was a network error here.
You
So
can continue. It's okay.
Yeah. Yes. So as a health workers, we need to change the catheter. There it was changed so that it cannot cause sepsis to the client. Then the constipation continues, even the difficult in passing stool. So it was there that Diclofenac was prescribed together with glycerin, but since the patient have difficulties in passing stool, until clients did EUA, that is the evaluation under anesthesia on the 31st of July 2023. I think that is where they took the biopsy there after discovering that the patient has got a mass there in the rectum. Then the transfusion continues since the patient loses some, not blood per se, but the HP was keep on going low. Despite that, he was having some iron tablets, multivite for raising the appetite. I can see there's even cephaloclo, maybe there was a bit of infection. And the last one there, you can see there's bicalutamide. With bicalutamide, it's a medical castration. It's medical castration. We know clients with prostate cancer, the prostate the network. I'm sorry about the network, people. So I'm saying here there's bicalutamide down there, which was prescribed. Since there's cancer, there's prostate cancer, enjoy the testosterone that is produced by the testicles. So when giving bicalutamide, we're trying to suppress the testosterone so that it cannot be produced, that even the cancer becomes dull. Yep. So I continue.
Yeah.
Then those were the results. That's why the results that was received from our laboratory that confirmed the cancer from the anal region. Yeah, those were the results that confirm the cancer from the rectum. So the doctors make decisions based on this result. Now, yeah, this is what I've been talking about. The physician, I mean the consultants, the doctors, they then refer to the surgeon. After seeing the results, the client was referred to the surgeon. Now client is being admitted today on the 30th of August.
Oh.
There's a new diagnosis up there. It says CA colon. That was confirmed by these results. Then there's nystatin that was prescribed as well for the fungal infection. I think that marks the end of my presentation, not unless there are questions.
Thank you, Cyprian, for the lovely presentation. I think even with the slides that you were able to share just now, we were able to follow quite well on what has happened with the client. So at this point, colleagues, if we have any questions or comments or recommendations on how this patient can be well managed, please use the raise of hand or write in the chat box. Okay, there's a hand from Mr. Mashamu.
Yes. Thank you so much, team. I just want to start first before you complete my questions and recommendations. Thank you so much, Mr. Matsenja, for showing us this patient. Actually, even the further information you have shared, thank you so much for that. It is well recommended to share with us so we can know what is happening. And thank you so much for being an advocate for such a patient. As you are doing this, actually, I just have few things. Maybe I will then come with anything to say. Maybe if possible, you can give us any information if it's available in terms of how long has the system have this patient with you, whether from when was the patient diagnosed, and how long has the patient has been with you, and then also the issue of the purpose of the chemo. What was the goal of the chemo for? And then also maybe if you can help us with the prostate cancer stage, if it's also available, maybe we can then I can then say some certain things. I think I need that issue. How long have you been with the patient, and when was the diagnosis done? And then the issue of the purpose of the chemo together with the staging of the prostate, if you do have, you know.
Okay, well noted, Mr. Mahlangu, but the patient, I've been with the patients, I think it's over a year now. Luckily, I know this patient because my teacher from the high school level, my mathematics teacher. I'm not very sure when was he diagnosed for the prostate cancer, but for the colon cancer, it's 2 weeks now. He has been diagnosed. And for prostate cancer, it is stage 3. For colon cancer, it's not yet stage, since we've got challenges with our radiology department doesn't have contrast. You know, for staging, you need to go to the CT scan, you do the X-rays there, you come with the reports from the radiologist, then that is when you can stage to see how far the cancer has been gone. But it's a different cancer. It doesn't emanate from the prostate. That one is different because we know with prostate cancer, normally it metastasizes to the lumbar spine. But as for this one, as for rectal cancer, it doesn't go to the lumbar spine. It's only prostate cancer that goes to the lumbar spine as far as I'm concerned. So these cancers are different. I don't know what I've answered all.
Thank you, Mr. Matse. Okay, thank you.
I don't know if Mr. Masam has any follow-up questions.
No, I don't have. I just wanted to understand the scenario of how long the patient has gone through with this cancer. I just wanted to say that we are not happy that maybe it has been now that the issue of rectal cancer has been diagnosed, because it might be that it has been there for a long time. I just wanted to say, but we are happy that finally they found that it's another cancer. I'm not sure how the breaking of bad news happened, but I think Mr. Matega got the opportunity to assess the patient's emotional and well-being and how they are coping now with the second diagnosis. But what I can say is that one of the things we have shared or touched on in this session, it's unfortunate that we are so still small in number, but this is a very critical area. Mr. Matega shared that the patient has a history of complaint and prescription of laxatives and the stuff. I'm not sure if the issue of fasting still has been there for a long time, but it has did. If then, as healthcare workers, we could do comprehensive pain assessment, we will be able to detect this as early as possible. Under the principles of pain assessment is that you can check the characteristics of the pain, where is it coming from, and then look at its function, how does it affect the patient's functionality. And then you look at the other interventions that have been done to deal with the issue. And then you look at the records, how long has the patient been doing this. And then there's this critical area that we say, then we conduct what we call focused physical examination to elicit any underlying cause, so that we can detect such issues like this that we may know as early as possible. The last issue was, I wanted to know what was the purpose of the chemo for the stage 3 cancer, and how far has it been with the patient now that it has been completed, what is the evaluation. But now Mr. Cyprian has gone, but that's what I heard, because then I think way forward from here is the issue of finding a way forward on the staging of the current cancer now, the second one, with the other cancer, to see then the goals of care. If there is palliative chemo or curative chemo, and where are we standing? Mr. Matsenga said that the patient is emaciated, and anorexia has led to even to the development of candida. So I think those are the issues that then we need to evaluate on terms of the treatment going ahead. So there's also issue of that the patient now is on colostomy and the catheterization of urine. So I think also those issues need to be addressed in terms of how is the patient capacitated in terms of infection control at home. And on especially on this area, focusing also closely to the caregiver and the wife, you know, other than looking at the medical side, the prescription, the surgical procedures and stuff. What about the psychosocial spiritual part of the patient? I think that one also needs to be looked closer, and we need to build the support there. I think that one is very important, because to me, this patient is descending down the trajectory of life. So the disease trajectory is going down. So I think we need not to blind our eyes in terms of death coming on the way, looking at that the patient is little bit going down a bit by bit. The reason I asked Mr. Matseja, how long have you been with the patient? I wanted to ascertain that if you look at the functional status of the patient the 12 months ago and now, how functional is the patient? Because that one will tell you that how long a patient is going to be with us, or the journey the patient is taking. That are we improving, or slowly but slowly we are going down? But if that's the case, advanced care planning must be always be there. The goals of care must be centered around how to improve comfort and preparation of the future that we don't know. Thank you so much.
Thank you, Mr. Mashangu. I think that we will probably request Mr. Matsenjwa to probably share feedback with us on our next session, maybe on some of the information that he can get about the client, mostly on your concerns and questions that you have actually raised. There's also a comment from Tandazile, which says, I am not sure how best can the team work around involvement of medical officers or prescribing officers in such platforms. I am seriously concerned about chronic pain management generally. Yes, we may advocate to a certain extent, but as long as we do not deal with the root cause, we will never win. For this client, there was a time, there was a time probably where the client only got tramadol, and also we need to be more aggressive in as far as depression management is concerned. So I think Tandazile is raising very important points in this comment. Issues of pain management, looking at some of the medication that the client has had, probably in comparison with the pain scale, and also issues of depression management. I think it also goes back to what Cyprian said about working as a multi-disciplinary team in managing our clients. I don't know if there's anything that Cyprian would want to say with regards to Tandazile's comment, or anything that you'd like to say maybe in concluding based on everything that has been said about the case.
Thank you so much, Miss. I think I can compare with Tandazile. I don't know the patient. I not in terms of the prescription or length term of tramadol, but my worry is we need the doctors to be here. Unfortunately, most of our physicians, I would say so, in the country that we have, they are too busy people available for in-service. Such that in some facilities, it's very difficult even to have an in-service for just physician in a facility-based setup. So yet these are the issues we will face as nurses as we are working and advocating for this. And especially when it comes to chronic pain management, chronic pain management, and now we understand that this is a brain problem. And if you're gonna stick on the pharmacological, you might not win. And if you're gonna stick on the non-pharmacological alone, you might not win. So it requires an aggressive team and psychiatric management, because the patient is already at the brink of developing substance use disorders if not taken care of well. So we have a challenge. I don't know how we can mobilize them, but if possible, in your different facilities, invite them when you are joining these sessions to just be with them, request them to have time, that hour or two to be in this platform. It's unfortunate that at the end of November, we will just write our test for this session since last year and then roll it up. But then we don't eliminate the need. If ever there will be a need for redoing certain sessions, we will come back and do them, because the purpose of this platform is to capacitate one another in helping the patient, because today is the patient, tomorrow it's me or it's my relative. So we need to capacitate one another in doing this. It's very painful when you know, and then you'll find that your relative, they have done half job and they knew this is what they were supposed to do and the resources were there. So if possible, the physicians are there, please invite them to come. If ever they need registration to with the platform, I'm available to help them with the link. So, we are available to support them. But we can work together as a team to say, if you are close to a certain doctor in your facility and you know she or he can benefit from the platform, please invite them. We have some doctors who have been registered to this platform, but some have not even attended one session. And I'm sure they are receiving our reminder sessions and invitations every time, but they don't make time. So I think we need to engage them, like physically engage them, invite them, give them the value of the platform. Because I'm promising you, we have learned a lot, and I believe we all learned a lot. And we are not the same like we were when we started this pain series. So yeah, I think that we can all work together. Anyone who's close to a doctor, put that doctor next to you during a session. In the coming months, they will be engaging our Ugandan experts, the professors. There are topics that we want them to engage us on under this chronic pain check on IECO. So it's gonna be great. So they are missing a lot. But please engage them, invite them to be with you. They will end up understanding what you are doing. Thank you.
Thank you, Mr. Mahlangu, for for sharing that. And thank you so much, Cyprian, for the tremendous job you have done in taking care of this patient. I think this marks the end of our session, colleagues. I hope Mr. Mahlangu will share the feedback link in our chat box, which we are encouraged to click and probably give feedback on how today's session went. So for our following session, it will be on the 13th of September, and we will be looking at treatment strategies for opioid use disorder. So please invite other colleagues, as Mr. Mahlangu has said, the doctors and any other medical officers to join us for these sessions so that we can all be able to benefit, share, and ask questions. So thank you so much, colleagues, for joining us in today's session. See you on the 13th.
Thank you.
Bye.